Stand up right now. Just stand up from wherever you're sitting. It took less than 2 seconds. You probably did not think about it. You certainly did not feel anything unusual. And yet, in the moment you rose from that chair, your cardiovascular system executed one of the most sophisticated emergency response protocols in human physiology. 500 milliliters of blood, roughly a full water bottle, shifted downward into your legs by pure gravity in under a second. The venous return to your heart dropped. Your cardiac output fell. The pressure driving blood to your brain decreased. And if your body had not responded to that pressure drop within 2 to 3 seconds with a precisely calibrated cascade of autonomic commands, you would have blacked out and fallen to the floor. This happens every time you stand up. 30 times a day on average, sometimes more. Every time you rise from a chair, from a bed, from the floor, from a crouch, gravity pulls blood into your lower extremities, and your cardiovascular system launches a coordinated emergency protocol to prevent your brain from losing its blood supply. You do not notice it because it works, but you have noticed it failing. Those times when you stood up too fast and everything went dark at the edges of your vision for a moment, when you felt lightheaded and had to grab the nearest surface, when stars floated briefly across your visual field before everything resolved back to normal. That was the protocol running slightly behind schedule. The pressure in your brain dropped below the threshold for full consciousness before the correction arrived. The stars you saw were your visual cortex losing perfusion pressure. And in that brief, disorienting moment, you had a direct sensory experience of a physiological event that is usually invisible, running silently 30 times a day, keeping you upright and conscious every time you rise against gravity. To understand what is happening, you need to understand a fundamental problem of vertical living. Humans are tall. When you are lying down or sitting, your cardiovascular system maintains relatively uniform pressure throughout the body. The heart, the brain, and the major vessels are all roughly at the same gravitational level, and the pressure required to perfuse the brain is similar to the pressure throughout the rest of the vascular system. The moment you stand up, everything changes. Your heart is now approximately 30 centimeters below your brain. Your lower legs are approximately 1 meter below your heart. Gravity pulls blood downward continuously. The veins in your legs, which are low-pressure, high-volume vessels with thin, compliant walls, can accommodate a large volume of blood. When you stand up, the venous hydrostatic pressure in your legs increases dramatically. The venous walls distend, and blood pools in the venous capacitance vessels of the lower extremities. This pooling can sequester 500 to 1,000 milliliters of blood. Removing it from the central circulation, reducing the volume returning to the right side of the heart, and dropping cardiac output within 1 to 2 heartbeats of the postural change. The consequence of this sudden drop in cardiac output is a drop in arterial blood pressure throughout the body, including in the arteries supplying the brain. Cerebral perfusion pressure, the pressure driving blood through the cerebral vasculature, falls. If it falls far enough, cerebral blood flow decreases below the threshold required to maintain consciousness. Syncope, what most people call fainting, can occur within 10 to 15 seconds of an uncorrected orthostatic blood pressure drop. Your brain, with its extraordinary metabolic demands and its total dependence on continuous blood flow, cannot tolerate even brief interruptions in perfusion without consequences. The system that prevents this from happening is the baroreflex, one of the fastest and most precisely calibrated feedback control systems in the human body. The baroreflex operates through specialized pressure-sensing neurons called baroreceptors, located at 2 critical anatomical positions in the cardiovascular system. The first and most important set of baroreceptors is located in the carotid sinus, a widened segment of the internal carotid artery just below the point where the common carotid artery divides in the neck. The second set is located in the aortic arch, the curved portion of the aorta that rises from the heart and bends downward into the chest. These baroreceptors are mechanoreceptors, neurons whose cell membranes are stretched by the pressure of the blood in the vessel wall. When blood pressure is high, the vessel wall is stretched more, the baroreceptor membranes are deformed more, and the neurons fire at a higher rate. When blood pressure drops, the vessel walls relax. The stretch on the baroreceptor membranes decreases, and the firing rate falls. This change in baroreceptor firing rate is the signal that initiates the entire orthostatic response. The afferent nerve fibers from the carotid sinus baroreceptors travel in the glossopharyngeal nerve, the ninth cranial nerve, to the nucleus tractus solitarius in the brainstem. The aortic arch baroreceptors send their signals via the vagus nerve, the 10th cranial nerve, to the same nucleus. The nucleus tractus solitarius is the primary central processing center for cardiovascular regulation, integrating baroreceptor input and coordinating the autonomic output that controls heart rate, cardiac contractility, and vascular tone throughout the body. When you stand up and blood pressure drops, the baroreceptors in the carotid sinus and aortic arch detect the reduced stretch in the vessel walls and decrease their firing rate. This decreased afferent input to the nucleus tractus solitarius is interpreted as a blood pressure emergency. The nucleus tractus solitarius responds by increasing sympathetic outflow through the cardiovascular centers of the brainstem and simultaneously decreasing parasympathetic outflow through the vagus nerve to the heart. The net effect is a rapid, coordinated autonomic response with three simultaneous components. First, heart rate increases. The withdrawal of vagal tone to the sinoatrial node allows the heart to accelerate. Within the first 2 to 3 heartbeats after standing, heart rate typically rises by 10 to 20 beats per minute. This increase in heart rate, called the reflex tachycardia of the orthostatic response, increases cardiac output, partially compensating for the reduction caused by decreased venous return. Second, the peripheral vasculature constricts. Sympathetic nerve fibers to the smooth muscle cells in the walls of arterioles throughout the body, but especially in the splanchnic circulation of the gut and the cutaneous circulation of the skin, increase their firing rate. The arterioles constrict. Total peripheral resistance rises. Higher peripheral resistance means higher arterial blood pressure for the same cardiac output. The vasoconstriction begins within 2 to 3 seconds of standing and is largely complete within 15 to 20 seconds. Third, and occurring on a slightly longer timescale, the veins themselves constrict. Sympathetic innervation of the venous smooth muscle in the legs and splanchnic bed increases venous tone, compressing the distended venous capacitance vessels and pushing the pooled blood back into the central circulation. Increased venous return to the heart increases cardiac filling, restoring stroke volume and cardiac output through the Starling mechanism, the heart's intrinsic ability to contract more forcefully when its chambers are more filled. The entire response, from the initial blood pressure drop to the restoration of adequate cerebral perfusion pressure, takes between 15 and 30 seconds in a healthy young adult. During that window, cerebral blood flow is transiently reduced, and the brain operates on a slightly lower perfusion pressure than normal. In most people, under most circumstances, this reduction is subclinical. The brain receives slightly less blood for a few seconds, but not enough less to produce symptoms. In some circumstances, including rapid standing after prolonged sitting, standing up while dehydrated, standing up after alcohol consumption, or standing up while taking certain medications that blunt the sympathetic response, the orthostatic blood pressure drop is larger. The compensatory response is slower or weaker, and the reduction in cerebral perfusion crosses the threshold for symptoms. The visual field dims because the visual cortex at the back of the brain is at the highest point of the cerebrovascular tree and experiences the greatest pressure reduction first. The stars you see are phosphines produced by transient ischemia of the visual cortex. If the pressure drop continues for another few seconds without correction, you lose consciousness entirely. This mechanism, the full orthostatic response from baroreceptor detection to sympathetic activation to blood pressure restoration, is happening in your body right now as you stand or sit reading this. It happened when you got out of bed this morning. It happened when you rose from the table after breakfast. It will happen every time you stand for the rest of your life. And in a healthy cardiovascular system with intact autonomic function, adequate hydration, and normal cardiac output, it works with remarkable precision, restoring blood pressure to near baseline levels so quickly and so smoothly that you feel nothing at all. But the orthostatic response is exquisitely sensitive to the health of the systems that execute it. And this sensitivity makes it one of the most informative clinical windows into cardiovascular and autonomic function available to physicians. Orthostatic hypotension, defined as a drop in systolic blood pressure of 20 millimeters of mercury or more within 3 minutes of standing, affects approximately 5% of adults under 60 and 15 to 20% of adults over 65. In the very elderly, in those with Parkinson's disease, in diabetics with autonomic neuropathy, in patients with heart failure or severe dehydration, the prevalence rises dramatically. And orthostatic hypotension is not merely uncomfortable, it is dangerous. Falls in the elderly, one of the leading causes of injury-related death and disability in the United States, are disproportionately associated with orthostatic hypotension. The sequence is predictable. The patient stands up, the baroreflex response is delayed or insufficient, cerebral perfusion drops, the patient loses balance or consciousness and falls. The fall itself may cause the injuries that ultimately prove fatal. The orthostatic response is not a physiological curiosity. It is a life-preserving mechanism whose failure in vulnerable populations kills. What makes the baroreflex response less effective with age? Several mechanisms converge. The baroreceptors themselves become less sensitive with age, requiring a larger pressure change to generate the same afferent signal. The autonomic nerve conduction velocity slows. The heart becomes less responsive to sympathetic stimulation, partly because of reduced beta-adrenergic receptor density, and partly because of the structural changes in the aging myocardium that reduce its ability to accelerate quickly. The veins become less compliant and less responsive to sympathetic vasoconstriction. And many of the medications prescribed most commonly to older adults, antihypertensives, diuretics, alpha blockers, nitrates, tricyclic antidepressants, directly blunt one or more components of the orthostatic response, either by reducing blood volume, by blocking sympathetic vasoconstriction, or by reducing cardiac responsiveness. The pharmacology of aging and the physiology of aging converge on the orthostatic response in ways that make standing up the most ordinary physical act of daily life, a genuine physiological challenge for a significant fraction of the elderly population. Dehydration affects the orthostatic response through a straightforward mechanism. The baroreflex can correct for the shift of blood volume to the legs by increasing heart rate and vasoconstriction, but these corrections have limits. If total blood volume is reduced by dehydration, the venous pooling that occurs with standing removes a larger fraction of the available circulating volume, and the compensatory mechanisms have less blood to work with. Even mild dehydration, a loss of 1 to 2% of body weight in fluid, can significantly worsen orthostatic blood pressure drops and cause symptomatic lightheadedness on standing in otherwise healthy adults. Alcohol exacerbates this through two mechanisms. It is a diuretic that reduces blood volume, and it is a vasodilator that blunts the sympathetic vasoconstriction response. The combination of alcohol and dehydration on standing blood pressure is why people who have been drinking are at significantly elevated risk of orthostatic syncope when they stand up quickly after sitting or lying down for extended periods. Exercise training, particularly endurance exercise, improves orthostatic tolerance through several mechanisms. Regular aerobic exercise increases plasma volume, meaning there is more circulating blood to begin with, and the relative reduction from orthostatic pooling is smaller. Exercise training increases baroreflex sensitivity, meaning the baroreceptors detect pressure changes more accurately and trigger faster autonomic responses. Exercise training increases cardiac stroke volume, meaning the heart can compensate more effectively for reduced venous return. And exercise training reduces resting heart rate, which means there is more room for the compensatory tachycardia to occur without reaching rates that impair cardiac filling. The orthostatic response of a well-trained endurance athlete is measurably faster, more accurate, and more robust than that of a sedentary person of similar age. Now step back and consider what all of this means for the 30 times a day you stand up. Each standing event is a small gravitational stress test of your cardiovascular and autonomic nervous system. Each one triggers a closed-loop feedback control response involving pressure sensors in your neck and chest, neural processing in your brainstem, sympathetic output to your heart and blood vessels, and mechanical response in the vasculature of your entire body. Each one is resolved within seconds by a system whose design was refined over millions of years of bipedal evolution. And the quality of that response, its speed, its accuracy, its completeness, is a direct reflection of the health of your cardiovascular system, your autonomic nervous system, your hydration status, and the medications and substances in your body at that moment. The stars you see when you stand up too fast are not a minor annoyance. They are a diagnostic signal. They are your brain telling you, in the most direct perceptual terms available, that the orthostatic response was not fast enough, that your cerebral perfusion dropped below threshold, that something in the system, hydration, vascular health, autonomic function, cardiac output, was not optimal in that moment. And if you see them frequently, or if they are accompanied by prolonged lightheadedness, or if you actually lose consciousness when standing, you are receiving a signal that deserves medical attention, because the system that is struggling is the same system that keeps you conscious and upright through every standing moment of every day. That is the emergency protocol that runs every time you stand. Silent, invisible, autonomic, precise. 30 times a day. Applied biology in the most ordinary act of human life. Happening right now in the 2 seconds it takes you to get out of a chair. There is one more dimension of the orthostatic response that most people never consider, and it connects the simple act of standing up to some of the most fundamental principles of engineering control theory. Because what the baroreflex actually is, stripped of its biological terminology, is a proportional integral feedback control system, and understanding it as an engineering system reveals why it is so good at what it does and exactly where and how it fails. In engineering, a feedback control system has 3 basic components: a sensor that measures the variable you want to control, a controller that compares the measured value to the desired set point and calculates the appropriate correction, and an actuator that applies the correction to the system. The baroreflex has all 3. The baroreceptors are the sensors, measuring arterial blood pressure continuously. The nucleus tractus solitarius and the cardiovascular centers of the brainstem are the controller, comparing the current pressure signal to the set point and calculating the required autonomic output. The heart and the vascular smooth muscle are the actuators, changing heart rate, contractility, and vascular resistance in response to the autonomic commands. What makes the baroreflex particularly sophisticated as a control system is that it operates on a very short time constant, meaning it detects errors and corrects them quickly, and that it has multiple actuators operating in parallel: the heart rate response, the arteriolar vasoconstriction, and the venous tone response, each with a slightly different time course and a slightly different contribution to the total correction. The heart rate response is fastest, occurring within 2 to 3 beats. The arteriolar vasoconstriction is slightly slower, developing over 5 to 15 seconds. The venous venoconstriction is slower still, reaching its full effect over 15 to 30 seconds. This staggered time course of correction is actually a feature of the system's design, not a limitation. By applying corrections on different timescales, the baroreflex avoids the oscillatory instability that would occur if all corrections arrived simultaneously. A control system that overcorrects produces oscillations. The controlled variable swings above and below the set point repeatedly before stabilizing. The baroreflex's staggered corrections produce a smooth, damped return to baseline blood pressure without overshoot. This is control systems engineering, implemented in biology, refined over hundreds of millions of years, operating in your brainstem and your vasculature right now. Every time you stand up, your body runs an engineering calculation that most mechanical control systems would envy. It detects a pressure error, calculates the required corrections, applies them in a time-staggered sequence to avoid oscillation, and restores the controlled variable, your blood pressure, to within a few percent of its set point within 30 seconds, from a perturbation that removed 500 milliliters of blood from the central circulation, without any conscious input, without any awareness on your part, 30 times a day. The Aging and Disease states that impair this response are, from a control system's perspective, failures of specific components. Reduced baroreceptor sensitivity is a sensor failure. Autonomic neuropathy is a failure of the neural transmission between the sensor and the controller, or between the controller and the actuators. Reduced cardiac responsiveness is an actuator failure. Medication-induced blunting of sympathetic vasoconstriction is a pharmacologically imposed actuator limitation. Each failure mode produces a characteristic pattern of orthostatic blood pressure response that, to a physician who understands the underlying control system, is diagnostically informative about which component is failing and why. There is also an underappreciated connection between the orthostatic response and cognitive function in older adults that has emerged from research in the last decade. Studies have found that older adults who show larger and more prolonged orthostatic blood pressure drops have greater white matter changes on brain MRI, higher rates of cognitive impairment, and faster rates of cognitive decline over time. The proposed mechanism is cerebral autoregulation, the brain's intrinsic ability to maintain constant blood flow across a range of perfusion pressures. Cerebral autoregulation normally buffers the brain against the transient pressure drops of orthostasis. But with age and with cumulative cerebrovascular disease, autoregulation becomes less effective. The repeated small drops in cerebral perfusion that accompany each orthostatic episode, normally handled invisibly by autoregulation, begin to produce cumulative microvascular stress that contributes over years to white matter injury and cognitive decline. The 30 daily standing events that are physiologically inconsequential in a young, healthy brain may, over decades, in a brain with aging vasculature and impaired autoregulation, contribute meaningfully to the trajectory of cognitive aging. This is not an argument for sitting more. Quite the opposite. The orthostatic response, like every other cardiovascular reflex, is improved by regular physical activity. The standing events that stress the system are also the training stimuli that keep the system robust. What matters is understanding that the quality of the orthostatic response is a meaningful marker of overall cardiovascular and autonomic health, and that the factors that preserve orthostatic function, regular exercise, adequate hydration, blood pressure management that does not overdose antihypertensive medications, and early treatment of conditions like diabetes that damage autonomic nerves are also the factors that protect brain health and cognitive function over a lifetime. Stand up. Notice nothing unusual. Feel no stars, no dimming, no lightheadedness. That nothing that you feel is the sound of a finely tuned control system working exactly as designed. Baroreceptors firing in your carotid sinus. Signals traveling to your brainstem at 40 meters per second. Sympathetic commands accelerating your heart. Arterioles constricting throughout your body. Venous tone increasing in your legs. Blood returning to your heart. Pressure restored to your brain. All of it in the 2 seconds between seated and upright. All of it invisible, all of it essential. That is the emergency protocol you launch 30 times a day. That is the engineering in your brainstem. That is applied biology, standing up with you every single time. Now you know what it is doing. Let me give you one final piece of this picture, because it connects the orthostatic response to something you have probably experienced without ever understanding its cause. It involves the morning, and it involves why the first stand of the day is physiologically the most demanding orthostatic challenge you face. When you're lying down during sleep, the orthostatic stress is absent. Blood distributes relatively evenly throughout the vascular system. Venous pressure in the legs is low. Cardiac output can be maintained with a lower heart rate and lower sympathetic tone. Your body takes advantage of this reduced cardiovascular demand during sleep to downregulate sympathetic activity and allow the cardiovascular system to rest. Heart rate falls, blood pressure falls, vascular tone is reduced. This is normal and beneficial. The resting cardiovascular system during deep sleep operates at significantly lower energy expenditure than during waking activity, and this nightly rest is part of what maintains cardiovascular health over a lifetime. But when you wake up and prepare to stand for the first time after 6 to 8 hours of horizontal rest, the cardiovascular system has to transition rapidly from a low-demand sleep state to a full upright orthostatic challenge. The sympathetic nervous system, which was suppressed during sleep, has to ramp up quickly. The baroreceptor set point, which shifts downward during sleep, has to reset upward. The blood volume, which may have shifted somewhat due to the horizontal position and the hormonal changes of sleep, has to redistribute to accommodate the orthostatic challenge. All of this transition happens in the seconds around waking, and it is why the first stand of the morning is statistically the most likely to produce orthostatic symptoms. This is why so many heart attacks and strokes occur in the early morning hours, not primarily because of the orthostatic response itself, but because of the broader cardiovascular stress of the sleep-to-wake transition, which involves a sharp rise in sympathetic activity, a rise in heart rate and blood pressure, a rise in platelet aggregability, and an increase in arterial wall stress, all occurring simultaneously in the first hour after waking. The orthostatic challenge is one component of this broader morning cardiovascular surge, and in people with underlying cardiovascular disease, the morning orthostatic response can be the trigger that tips a vulnerable plaque into rupture or a critically narrowed coronary artery into spasm. This is not a reason to lie in bed indefinitely every morning. It is a reason to understand that the cardiovascular system has a biological morning preparation sequence, and that supporting that sequence with adequate hydration before standing, with a gradual rather than abrupt transition from lying to upright, with morning physical activity that trains and maintains the orthostatic reflex, is a meaningful part of cardiovascular health maintenance. The elderly person who sits on the edge of the bed for 30 seconds before standing, a piece of advice given by geriatricians for decades, is not being overcautious. They are giving the autonomic nervous system time to ramp up its sympathetic output before the full orthostatic gravitational challenge arrives. They are giving the baroreceptors time to recalibrate. They are giving the heart time to increase its rate and contractility before the venous return drops. It is not caution. It is physiology. The 30 times a day you stand up are 30 cardiovascular events. In a healthy young body, they are so seamlessly managed that you never know they happened. In an aging body, a dehydrated body, a medicated body, or a body with compromised autonomic function, each one is a genuine challenge that the system meets with varying degrees of success. The stars you occasionally see are the failures. The smooth, uneventful standings are the successes. And the difference between them, played out across 30 events per day for decades, is the difference between a cardiovascular system that ages gracefully and one that accumulates damage faster than it needs to. Stand up, feel nothing, and know that the nothing you feel is 30 million years of primate cardiovascular evolution, running a control algorithm in your brainstem, restoring 500 milliliters of displaced blood to your central circulation, and keeping your brain perfused and your consciousness intact in the 2 seconds it takes you to go from sitting to standing. Applied biology, 30 times a day, every day, for the rest of your life.